points of the need for us to be focusing on the very urgent operational issues. And not only that, the Scottish Government, any seconded staff from His and other places were returned to their home boards so that they could contribute to that. So there was no infrastructure nationally. However, that has now been stepped back up. So I suppose in summary, we're in a different place now to when this paper was probably most relevant, so my apologies about that. But you had quite a number of detailed updates previously, which hopefully have given you a deeper dive in some of the flavour of what's been happening. But I would like to use this paper just to emphasise that bit is now done, and much of clinical governance in the Health Board is essentially back to business as usual. So thanks for letting me go up the agenda with that, Fiona. Appreciate it. If people do have questions from that brief paper, I'm more than happy to try and answer them.
Thank you very much, Andrew. I think certainly the information around the care homes assurance, and I think that the system that was put in place, and I think is across the partnership in public health and with care homes themselves, I think does give assurance that issues will be picked up and will be picked up quickly, and I think. I think I've said it before, but I think that the work that was involved in that, I think that everybody involved, I suppose it's a big thank you for all that work involved, because I know it was a very difficult time. I suppose I've got one question on it.
Sure.
Was just around this is it's obviously a current live. It's not in the past. It's a current live ongoing a position, but I suppose it's that assurance around we're now in a different phase where we're talking about visiting and that visiting indoors, which is the next step and the more risky step, and I suppose it's around the system picking up any issues and mitigating that risk as best it can.
I think that's one of the key points we were discussing just yesterday. So I am going to invite, because you've got the experts on this call, Fiona, you've got Angela and you've got Ellen, and the fact there's a whole cast of us who were on those calls yesterday, and Patricia, Lorraine, Ellen and Martin and Sarah. So I'm really going to hand that question over to maybe Angela as chair of the assurance group to maybe give you the most informed answer. Thanks.
Fiona, thank you. Can everyone hear me okay? Yeah. And come in first and then let me come in, or Patricia, did you want to go first?
No, it's okay.
Yes, as Andrew says, thanks, Andrew. Thanks, Patricia. On behalf of all of us, I was just typing in their chair that the care homes themselves have really responded so well to all this mutual aid and new world, and that can't have been easy for them. So I think on the whole, and Falkirk's position is pretty fantastic. So it's a real team effort. So agreed. Yeah, I mean the next stage of visiting is really concerning for homes, and I think half of that is really about trying to make sure that they do the right thing and that no infection can be introduced into home, and I think they are super cautious. From the Care Home Strategy Group colleagues and from the Oversight colleagues, we spent a lot of time on that yesterday, and we are seeing our care homes submitting their plans, Fiona, to be approved to allow this phase of visiting indoors and also to keep everyone safe, and that they are coming in slowly but well, and they are particularly of a high quality. There's a few homes around our whole system, not necessarily about Falkirk, which are going to need some encouragement to find that balance and risk of allowing visiting to happen but keeping residents safe. So, and we're working our way through that, and the Care Home Strategy Group, and Ellen might want to see that, are looking at the detail of that. I think there's a bit of a confusion across Scotland because of Tayside and Lanarkshire have got significant community outbreaks, and although we don't have community transmission as such at the moment in this scale, I think they have said that they're not going to do the third phase of visiting. So I think that's causing a bit of confusion for relatives, but we are sticking to doing the third phase of visiting as safely as we can. So, and everyone's preparing to do that. The strategy group thought, Fiona, about how we make sure we can monitor it and how we can support the care homes to really do the right things to make sure that people are safe. So we've got that in our sights. The strategy group are doing the detail, and the oversight group, as Andrew said, are looking at that on a weekly basis, or if anything changes in between times. So we're poised, prepared. Care homes are doing their best, and where people are just a bit anxious or need a bit of more support, we're just moving in the way we've done prior to try and help people keep everyone safe and sound. I hope that's helpful, and I don't know whether any other colleagues want to add to that.
Patricia. Thank you, Angela.
Thank you, Chair. Can you hear me? Yep. It was just to add to what Angela said, we've really had an excellent level of inter-agency working across the piece. We've had excellent uptake of staff testing across the care homes. You know, great cooperation and compliance with that. And the group is really meeting every new challenge as it emerges, with changing guidance, and also as we move out of phased lockdown. There is a wee bit of concern and resistance in the system, as Angela described, which is understandable, where care homes are really thoughtful about the risk, particularly when they see the small outbreaks and the larger outbreaks happening this week. So it's really about us working really closely with them, helping them to manage any risks, but also having at the heart of this the human rights and the well-being of the residents in the care homes, some of whom have had no contact with their families or no direct contact with their families for a number of months. So it's a really delicate balance, but we did have a really detailed discussion yesterday, and it's something and a question we will continually ask of ourselves at the strategy group and at the oversight group. But I think the one big bonus that's come out of all of this is the really close working between the care homes, the care providers, social care staff, infection control, palliative care nursing, community nursing, and the whole of the acute sector, including the geriatricians, the GPs and other clinicians. So we've come out of this, we're emerging this with some new relationships, new understandings of each other, and we will to work our way through the phases and all the challenges that may lie ahead of us. So thank you.
Thank you, Patricia, and thank you, Angela. That's very helpful. Is there any other questions on the paper? Stephen.
Thanks, Fiona. I suppose a slightly wider issue. Are we finding that there is a reticence from either residents or their families about admitting their loved ones to care homes at the moment? And as we're seeing that across the UK, there's some indication that there's an unwillingness to do that. And is that putting any pressure onto the kind of health and social care system? If that's the case, you know, what are our plans going forward to manage that kind of level of reticence?
Patricia.
Thank you, Chair. It's quite difficult to detect. A large number of our care homes are not accepting admissions at the moment, and we're carefully managing any admissions into care homes. They've got to meet certain criteria from public health, infection control and ourselves. We are running at about 80% capacity across the care homes in Falkirk. And we are working in line with the government guidance in subsidising those empty places with the providers. Falkirk partnership was the first partnership in Scotland to actually enter into such an agreement with their providers, and we did that right at the beginning in March because we identified a risk of some of them falling over if they didn't have a guaranteed income stream. So it's something that, you know, we've been working on, but you know, nationally and locally, there is a discussion just now about how do we taper that off, given the level of vacancies at the moment. In relation to Falkirk's delivery plan, we have in our sights to recalibrate that system. We do have a significant provision of care home beds, and we do tend to admit people earlier than the national average, and therefore they stay longer. So part of our delivery plan was to try to rebalance the system and move away from such a high level of bed-based care into more community-based care and a range of options to support people in the community. So you'll see that there's papers coming to the Ijb meeting next week around that service redesign. We're also involved in a Forth Valley-wide basis doing a community bed modelling capacity exercise, and that's looking across not just our care home beds but also our community hospital beds to try and model what our demand is and actually what should the models of care look like in order to provide step up and step down care, but also to provide reablement, rehabilitation in the community as well as in a bed-based care system. So there are opportunities locally for us to really look at how we recommission in the system. There is some risk because some of the larger providers may decide to, walk away from Falkirk or nationally, and we don't know, we don't have that intelligence yet. What is emerging is that over the last 5 months, if you're over 75, the safest place for you to be was in your own home. And also it would appear that smaller homes actually had less COVID and less spread of COVID, but that is anecdotal at this stage, and that evidence will emerge. So I would expect, and members of this group and members of the Ijb would expect, that there's a national review of social care, but also we'll be looking locally at actually what's the best provision that we can provide and how do we do that, taking on the learning from COVID and any national direction that there will be in that regard. So there's a lot of work going on just now with the providers. There's a lot of work going on nationally, but also at local level. So hopefully that answers your question.
No, absolutely, Patricia, thanks for that. That's a really good answer. I suppose I put my kind of health hat on in that respect. That synergy between both systems is really important, that we don't put pressure back onto health with delayed discharges and things of that nature. But I'm sure that will get caught up in the wider debate that you've updated us in there. Thank you very much.
Thanks, Stephen. Is there any other questions? I'll try to look at everyone.
I just popped into the chat just to make people aware, because it's a sort of similar piece of work. Our Director of Public Health is saying that they're now having daily calls just around the public health issues with schools, with all the head teachers. And again, I think that's probably based on some of the learning about how proactive people have been with the care homes. And that has been, we're hearing back just anecdotally, the head teachers really appreciate that level of proactive guidance that they're able to receive. So it's been a great bit of work that has that wider application now.
So I would probably add to that as a councillor and the emergency executive around some of the discussions and decisions around schools. I think certainly as Sarah's saying that from the Director of Children's Services that's coming through loud and clear about that support from public health is very, very important in the reopening of schools. Any other questions? No? Well, thanks very much, Andrew.
Just to say, Fiona, I won't bring anything back from the clinical governance side of things unless commissioned by yourselves to do so, if that's okay.
Righto. Okay. Righto. Thanks very much, Andrew. So I can move back on the agenda to the action log, and I think that's a carry forward and one that will continue until we're probably in a little bit more of a stable position, I would say. Perhaps not the time. So with that, I'd like to move on to the agenda item 5, remobilise, recover, redesign, update. Is that, I'm trying to see you on the screen. Is that you, Lorraine?
Yeah, I will go through this report with the group. Okay, so as the committee is aware, having read this report, this is an update on the work that the partnership has done with regards to remobilisation, recovery and redesign following the COVID-19 pandemic. It just outlines the work that was undertaken to ensure that essential services were maintained during the pandemic, and now that we're into recovery, re-establishing those services in line with the Scottish Government roadmap and the national framework. We're also building on lessons that were learned throughout the pandemic, and hoping to stand on those new initiatives that happened during that time. So the committee is asked to note the progress made with demobilisation, recovery and redesign via the updating of the partnership's delivery plan, and note the planned improvements to the service delivery, and note that there's two debrief reports that will be presented to a future clinical governance committee that are outlined in the report further on, which I will give mention to through the report. So I'm just scrolling through the report while on the screen. So I won't see anybody's faces or hands, so I'll take questions at the end. So as described, we were following the framework from the Scottish Government. At the beginning of the pandemic, we established our incident management team, which ensured that we kept essential services running to our vulnerable communities. We ensured that the community had support and that everyone was safe and well supported. We increased our Home First team capacity to ensure that we were discharging people from hospital on a timely basis and creating capacity in the acute sector. We increased our AHP capacity to 7-day working, and we increased capacity in our overnight service with MECs. We expanded the hospital at home services across both the community hospitals as well as Forth Valley Royal, and we worked with community nursing, the third sector, to ensure that we had as much support in the community for people as possible. We also developed a staff welfare and support network using regular bulletins, virtual coffee time, virtual staff chats and activities were promoted throughout the pandemic. We were able to sustain our core services through the pandemic, focusing on care at home and our community care, community mental health and support from technology. We did, however, suspend day services in line with the national lockdown requirements, and redirected staff who worked in those areas to support our essential services. Since we've been moving out of the incident management phase and response phase into recovery phase, we've been gradually re-establishing our services in line with all the direction and guidance around about managing COVID in our communities. As Andrew alluded to, we've changed quite dramatically the way that we work. We've got very limited footfall into any of our offices, ensuring that it is just essential workers who require to be at a desk for any period of time are. We are, as described as well, very much focusing on our care homes. We have established a partnership care home group, which has now evolved into CHART, which is mirrors what's happening in Clackmannanshire and Stirling. So CHART standing for Care Home Assurance and Review Team, and we've put an interim team in place so that we can support all the work that's happening around about the care homes, which has evolved over time, but as has already been said, is now very well established, and we have a very good mechanism to ensure there's support and assurance for the care homes. Whereas, as Patricia also mentioned, we're progressing a review of the functionality of the community hospitals, both Falkirk and Bowness community hospitals, and we're working with Buchanan Associates to establish the capacity model for community hospital beds as well as care home beds. We established short-term respite in Thornton Gardens. Thornton Gardens was a facility that we had available to us from, it was previously a sheltered housing complex run by Beeld. That was handed over to the partnership, and we had various thoughts about what we might use it for, but what has evolved out of the pandemic is that the requirement for respite during the pandemic, carers did really well supporting their families and their loved ones, but there has been stresses in the system since then. So we, in June, we reopened Thornton Gardens, and we're now able to provide respite for older adults and people with learning disabilities. in line with COVID restrictions, but that has been working very well to support people in the community. Obviously, finance is of concern, and we're keeping an eye on the expenditure that we've had through COVID. The 2 debriefs that were commissioned as a result of COVID, one was just the broad debrief on how we managed the COVID situation as a partnership, and we have an interim report on that, which we will be undertaking to review the actions and report back at the next committee. And the second one was with regard to the incident in Kinnaird Manor and the outbreak that happened quite early on in the pandemic, and the lessons learned from that, and we'll be reporting on that again in November. Just scrolling through this, I think everything else is there as read. The outcome of the work that has been done with the geriatricians to develop a hospital at home model for Forth Valley is underway, and that's Claire Copeland that's leading on that, and we're very much involved with the work that's happening to ensure that we can provide that higher level of care for people in the community to prevent hospital admissions when they're not required. And that's part of the Rapid Access Frailty Clinic and the ECT building on the work that's happened there. Okay. Just trying to pick out any other of the key points in the paper, but more than happy to take questions on any part of the paper. Thank you.
Thanks very much, Lorraine. I suppose just a couple of very quick comments, I think, more than anything else, before we open up to questions. I think the work around the enhanced care team, the geriatric enhanced care team, I think that's is very heartening hearing the initial results, and I'm very pleased that we're going to be building on that to support more people at home. So I think that's excellent. And I also just wanted to say that the route map as it applies to Falkirk and the partnership is very helpful in following what we're doing and when. So just thanks very much for that. So with that, I'll just open it up for any questions. Give me a wave if you have any questions. Yeah, I muted myself. Oh, yeah, we don't have any questions at the moment. So thank you very much for that, and no doubt we'll hear more. We will hear more as we go along. So thanks very much. Yeah. So our next paper is the Hscp Complaints Performance Report. Is that there? So that's Suzanne. Thanks very much.
Thanks, Chair. The timing of the Clinical Care Governance Committee meeting provided a good opportunity for us to prepare an annual complaints report, which will be a first to the committee. The report presents an overview of the complaints that were received about health and social care partnership services over the reporting year April 2019 to March 2020. You'll also see in one of the appendices that provides an update on complaints that were received for NHS services that transferred over to the Health and Social Care Partnership for the 2-month period from April to May this year. You'll have seen the report, so I'd just probably like to draw your attention to a couple of points from the report. At section 3, we note that work is required to refresh the complaints handling procedures, and that's for the Ijb itself, and also to introduce the new arrangements for complaint handling procedures for social work services. This work needs to be done for April next year, and we've started to do that, and reports will be brought forward to appropriate Ijb in due course. At section 4.13, we've included some information around the complaints to the SPSO. There have been 6 complaints in total over the year, and 2 of which have 2 complaint numbers. We've in the table put some updates where that's available, and for future meetings, the committee, we can also provide updates on those complaints as information becomes available. And finally, at section 4.14, we've included some information on Ijb complaints, and the committee will note that no complaints have been received over that year for Ijb as a public body in its own right. Happy to take any questions, but the committee is asked to note the content of the complaints performance report.
Thanks very much, Suzanne. You'll not be surprised that I've got a couple of questions, but one was a process thing around the table around the complaints to, and it was just to check out for my own understanding. The table around the SPSO talks about recommendations being made, and obviously I know it needs to be very careful about maintaining confidentiality, but I wondered whether we would normally be looking at what those recommendations were, or detailing that some of those recommendations were specific to the patient, for example. So I had that question for one, and my second question was around that there's a bit of an increase in complaints upheld around adult social work, but there's also a kind of drop in proportions dealt with at stage 2 within the timescales, and I just wondered, I suppose it's probably around data we're likely to see a non-comparable picture for the next year or the next period because of COVID. Are we going to be seeing something a bit different in how that data looks? So that was just a general question.
Yeah, thank you. In terms of the SPSO, and I guess with all complaints, we are very mindful when we've been developing these papers about confidentiality aspects. So particularly around the SPSO, we had quite a lot of discussion about, even by, case numbers, identifiable issues. So I think what we've been doing is looking at those thematically, and certainly some of the tables look at complaints by themes as well. So I think we're just probably going to have to consider that on a case-by-case basis. Still making sure we give appropriate assurance to committee that we're looking into these things, but being very mindful of any sort of confidentiality aspects to it. So I hope that perhaps gives some assurance. But yes, and certainly we certainly, where we can, are reporting by themes, so we get a general sense of it. In terms of the adult social work issues about complaints, I'll maybe defer some of that to Lorraine and Martin. However, just generally, given we're about to sort of look at a review of the complaints handling procedures for social work adult services, I think that also affords an opportunity to have those discussions with managers about how to respond effectively to complaints, particularly stage 1 and stage 2, and just to revisit that and share some good practice and learning. We've had good relationships with our patient relations team in NHS Forth Valley around complaints handling and the lessons learned. So I think it's just about continuing to sort of build on those relationships, particularly for complaints that are spanning both health and social work services.
Martin, thank you.
Just to pick up on, I guess, Suzanne's point there, I think when this report came a year ago, when Lorraine and I were new in post, we noticed that performance had dipped from the previous year. So we took some actions that we thought would have addressed this, which clearly they haven't, because I guess the data we get is before things reach the timescale, and what we always get told is things are on track. So I guess what this report really highlighted was that there are clearly issues, which is why we're buying into, I guess, the review of the whole complaints procedure. So we've allocated one of the locality managers and a service manager to lead up that review, because as you can see there, that performance isn't good enough. If it was 80–90%, I'd probably be saying it wasn't good enough. But the fact it's dipped now down to 41%, it's not great. So we are committed to that review. So hopefully next time this report comes, you will begin to see an improvement. And I would hope that within a year that performance is up to the high 80s.
Thank you, Martin. And thank you, Suzanne. Ellen, you wanted to come in?
It's actually Elaine, Chair, Head of Person-Centred Care. I just wanted to pick up on your point around SPSO, and I'm very mindful of the information shared in the report. I do think, if colleagues would like, we could expand a bit more information while still keeping confidentiality, particularly around the position element of the report we could expand a bit more if colleagues would be content for us to share a bit more, we could do that.
That's helpful. Apologies, I'm just reading names because it's a bit blurry at the moment.
Especially when people are changing chairs.
I know. I'm really confused. That's very helpful. I think it's about the when we have reports that we understand that how where potential issues are and what the improvement path is for that. I think that's really.
I think we could give more context in the position column, and I'm happy to do that.
Thank you.
Thank you.
Stephen, you wanted to come in.
Thanks, Fiona. Yeah, I mean, I think in the general on the round, the complaints, obviously fairly low number considering the sheer number of contacts that we have. But I suppose, and none against the Ijb, which in some respects is great, but I suppose having a very low or no complaints isn't always a great indicator of health and of the system. So I think two points. Are we confident that we are able to pick up in some of these issues? And again, it is, second point, it's quite difficult to have a statistical analysis when you've got such low numbers with a large number of contacts. And I kind of like the thematic themes. But one of the ones that comes up quite a lot, albeit again the caveat of large numbers of contacts, is Woodlands Resource Centre. So I suppose maybe just for the assurance of the committee, is it worth doing a deeper dive into a particular area of our business to give some reassurance that there is no kind of outstanding issues? And also, adding to my original point, are we comfortable that no complaints against the Ijb is a position of health?
Susanna, are you able to come back in on that?
Yeah, I do take the point. I think in relation to the Ijb, it's about its role as a public body, and it's about its action or lack of action and decisions that it would specifically make that would generate complaints. I guess how we would explore that, we can certainly give some thought to. But I guess the fact that we've got a lot of transparency in terms of our papers being published, our meetings being held in public, etc., might give some element of assurance. But we can certainly take that back to colleagues and give some more thought to that, Stephen.
Sarah?
Thank you, Chair. Just to develop the conversation, I suppose since the inception of Clinical Care Governance Committee, we've watched this particular paper evolve and change over time, and it's improved over time. We've now got much more detail for our assurance purposes. I do wonder whether the committee would want to consider how we focus and look at the learning outputs from complaints, and whether maybe more focus on that helps us manage the confidentiality issue that we've already been grappling with, and just given the importance of learnings from complaints and how we develop integration and our service delivery on the back of complaints, whether that might be something the committee would want to see us. Not entirely sure how we would do that, but I just wondered if that might be the next area of development for this particular area of our agenda.
Angela?
Yeah, just wanted to support Sarah and what Suzanne said prior. I think, and building on Elaine's point, I think this report has developed. I think it's become more mature. You can see the linkages as well. I think there is a room to, I'd absolutely agree with Sarah around sharing the learning, because what board members want to see is that we're not repeating the same experiences that people have had of our services and care. And the other thing that Sarah and I were talking about was about more user and citizen experience of our services, and we can kind of opening up the section around what people are feeling around our services. So I just wanted to support Sarah in terms of how we develop this. I think we can give more information, as Elaine said, and I think we would want to bring users and citizens more into the meeting as best we can. So I think with the colleagues' permission, Sarah and Patricia's team and our teams can continue to develop that in the way that the committee gets the widest possible picture. It sits beautifully with the IGB's priorities around engagement and listening and learning and improving our services using people's experience. So yeah, I just wanted to support Sarah, and I think we can continue to develop this so you can see that broad range.
That's great. Is that something that we can put down as an action to look at how this can be developed further? I wonder if is anyone able to pick up the particular point around the Woodlands Resource Centre around a deeper dive? Angela, are you able to pick that up?
Yeah, so I don't know whether Elaine was planning to come in there. So yeah, we can. I think unless you want the question answered today around there, or do you want us to bring further information back, Chair?
I wonder if you could maybe bring further information back, have a wee think about that, and maybe bring something back for the next meeting. Because I think it does. I think it's probably. I've got a wee note of it as well, and I have noticed it at other ones in previous reports as well. So
yeah, I think that's what Elaine was. Because when something goes, we work really hard. And I know all colleagues do, to make sure that if somebody raises a concern, that we investigate it fully, we listen clearly, we try to understand what results they wish. So as part of the complaints process, we do that. We do everything we possibly can to make sure that people feel satisfied we've taken it seriously and they can see change, because most people just want another loved one never to experience what they have done. If it goes to the Ombudsman, it means that we've not managed to do that for that family in relation to their loved ones, and then when it goes to the Ombudsman make a decision of whether we've investigated it well and whether we've answered the questions, or indeed that we have not upheld. And I think what Elaine was saying in relation to Woodlands and others, what you'll see is what we've done, what we've found, and if the Ombudsman have upheld things, and then there is learning from that, both either that we managed to answer it enough or not. So I think in relation to that, there is what families have said, what we found, and what the Ombudsman does. And I think what Elaine was suggesting is that you can see that broadness, Chair. Yeah. So you can see the issues, see that we've done the right thing, and also see if the Ombudsman has upheld the family or our position. And we will do that for Woodlands.
Okay, thank you. Jen, I know that you're wanting to come in. I've seen you waving.
Yeah, I'm just trying to remember, I was picking up on the point around participation and engagement and co-design, and absolutely I would always suggest that complaints are a key aspect to that, just because of the learning element. And perhaps if you have built a positive relationship with someone through that process of working with them to investigate it, you might want to invite them to come along and be part of an improvement group or something if they really are passionate about it and care. But absolutely, they're almost in some ways you can even use them as like monitoring indicators. And I would reflect that just if you look at the middle column of that table, a lot of those, if you could actually almost directly relate them to some care standards as well. So it doesn't represent all of the care, it's one small part of it. And if you represent them against the sort of semi-annual I'm trying to think of the ones, what you call that, I can't remember the name of it, where you look at the care standards and people are asked questions in the national surveys and your local surveys around that. Actually, that's a whole picture of most of the time we're getting it right and we're doing it really well. There's a small time where we're not. There's clearly at one place where we need to do a bit of work, but they're all linked. That's all. That's person-centered care issues, really.
Absolutely. Agreed.
Margot, you wanted to come in?
Right. Just to say that in all of this, the role of patient opinion is quite useful, I would think. And on the point about the complaints against the IJB, I'm not quite sure if the public are aware of its role in the mechanism for complaining.
Ellen? Sorry, it's not.
Sorry. Hiya, that's okay. I just thought it might be helpful if I share a bit of information about, Margot was saying patient opinion, but it's actually care opinion it's called now. It's kind of evolved on to being called care opinion. I've been in early discussions with the Falkirk Partnership around care opinion and Gemma Ritchie and I have had some early preliminary conversations. In health, we use care opinion as one of our ways of gaining feedback, and I think I mentioned that at a previous meeting. So we've been a bit delayed because of the COVID pandemic, but we are getting back on track, and I think it's something that would work well for the partnership in terms of another layer of feedback that would work well for not everyone. It doesn't work for everyone. It's not a one-size-fits-all feedback mechanism, but it is good for some clients and patients. So I think that's something that's new that will come along shortly.
Thank you. I wonder, Patricia, is there something, just a general question around the sort of public awareness of the Ijb and how to complain if they have specific issues? It's just a general question.
I think that's a valid point. You know, we do have it publicised on our website, but you would need to know we were there to look for us, basically. One of the posts that the Ijb approved the turn of the year was to get a communications officer, and our recruitment was paused during COVID, and we're now finalising the HR processes. And now that we are more integrated, we've got more of a story and our strategy will develop, and particularly around social media. So I think there is a fair point about raising our awareness. But as Suzanne said, the Ijb is the body that's making the decisions. It's not that we're not receiving complaints, because the services, both social work and the community health services and community nursing, are receiving complaints. So it's more of the partnership is receiving complaints from those two avenues. But complaints specifically about the Ijb would be taking issues with either the processes or the methods or the actual decisions that the Ijb was making. So it's a bit more complex in that regard. But you know, it is about raising people's awareness of it is actually making decisions, and it's charged with making decisions about key areas of community-based health and social care services.
Thanks, Patricia, that's helpful. Jen, you want to come back in again?
Sorry, I'm relatively new to this committee, so do we see those complaints as well as reports in this committee if they're part of the system, the whole system? Because I'm just conscious that this report focuses mainly on medical services, not social work. Possibly the answer is yes, I just haven't seen those before because I think it's on my third meeting.
Social work complaints are in the report.
Oh, sorry, okay, I've missed that. Okay.
Yeah, they're nearer the beginning.
Okay.
Or nearer the end. I'm getting confused.
Silly and embarrassing question. Look again.
Okay. Is there any further questions? No, thank you very much, everybody. And I am going to move on to the hospital-acquired infection performance report. Is that Jonathan?
Yes, it is, yeah. Good morning, everyone. This is the quarterly report for April to June of this year. First, I'll just talk to you quickly about about COVID-19. We've been monitoring COVID-19 since January. We look at international organism threats through various internet sites, and we were monitoring this way before it actually hit the media, and we kept. And in January, we notified the front door staff of to be aware of this before it reached the media in this country. So, we were quite well prepared for this way before it actually caused a bit of an issue for us. So we had our first positive case in the middle of March. And then by the middle of April, we peaked to about 65 inpatients in total. There's quite a very brief peak, but within 4 weeks, we'd actually halved our inpatient numbers, and then the numbers gradually declined. So, to a point where we had quite a number of weeks where we had no patients in hospital with COVID. We do have one patient in it, but that's been the first for a good while. In terms of other things, just to give the committee some assurance, we report on a weekly basis all our hospital onset COVID-19. So these are patients who have been in without any symptoms, without any, over a 14-day period. So we know that they haven't caught it out in the community, and those who have developed it within the hospital setting. And this is reported on a national basis. So give the assurance to the committee that we're sitting, our hospital onset rate is at 2.2%. The national rate is 5.8%. So apart from Dumfries and Galloway, which by all accounts looks like COVID has completely missed them. They must have gone straight up the motorway and past Dumfries and Galloway altogether. But we're the lowest mainland board for hospital onset COVID. So just got to give you the assurance of that. So we are in quite a good place in terms of hospital transmission. Moving on to the annual operating plan targets, these are the national targets. We have 3 targets: the E. coli bacteremias, Staph aureus bacteremias, and a Clostridioides difficile infections. Now, just to give a bit of background on the 2 bacteremias, the E. coli and the Staph aureus, well, I'll go on to the E. coli first of all. These are organisms that have been isolated from blood cultures. So people who've got symptoms of sepsis or septicemia, blood is taken, and then the bacteria is actually recovered from the blood. Now, E. coli is the most common organism isolated from blood cultures nationally, including England, Wales, and Ireland as well. So this is why there's a national appetite to actually reduce these numbers. It's quite a challenging one because E. coli is the most common organism that causes urinary tract infections. It's the most prolific and predominant organism in the gut. So it's a tricky one to actually to reduce in numbers. But having said that, we have been given a 25% reduction target, and we're working towards it. You can see in the graphs that our lines, we have had a couple of peaks in our targets, but I'll explain those later on as I go through each of the individual sections. But overall, we are kind of on target. Same with our Staph aureus bacteremias as well, and also for our Clostridium difficile infections. So moving on to our Staph aureus bacteremias, we had this quarter, we did have a slight increase in Staph aureus bacteremias from 8 the previous quarter to 14 this quarter, predominantly in our healthcare side of things. So these are people who have acquired the infection out in the community, but have had some form of healthcare interventions in the last 4 weeks. So for Falkirk and Bowness, there were no reported Staph aureus bacteremias for this period. Our device-associated bacteremias, so these are very different ones. This is something that we're doing uniquely in Scotland, and this is about, rather than chasing and looking at reduction of specific organisms, we're looking at infections associated with a specific device. So, and we thought this was more important, and we've been doing this since 2014 now, and so we report on these. This is not something that's reported nationally. This is something that we've identified locally, and so we find it's quite important. And again, we have seen a reduction in numbers, especially in the hospital ones. So that could be linked also to the reduction in our bed days. But again, for Falkirk and Bowness hospitals, that we had no reported cases of device-associated bacteremias. E. coli's, again, for Falkirk and Bowness, we haven't had any reported cases. We do have, as you can see in the overall hospital ones, healthcare ones, I beg your pardon, we have is the predominant challenging area. Now, these are people coming in with complicated urinary tract infections who have had infections via their urinary catheter and things like that. Now, we have seen a peak, and we did have a data exceedance in May of this year. We did have one last month as well. So we can only speculate there's people's reluctance to go and see their GP if they've had a bit of a urinary tract infection, and this then progresses to more serious condition. We're hoping once all this is out of the way, this COVID thing, if it ever does go away, that we will see a reduction and we'll go back to our normal levels. Clostridium difficile infections, again, for Falkirk and Bowness, we had no reported cases. Our numbers are very low, certainly our hospital-acquired ones, and I believe that we have probably reached now to an irreducible minimum. Now, these infections are not from patient-to-patient spread, so these are patients that have developed the infection following antibiotics, bearing in mind that Clostridium can be part of the normal flora. So it's very similar to infections such as like a yeast infection after antibiotics. The bacteria, if you're on broad spectrum antibiotics, some of the bacteria is destroyed and allowing the Clostridium to start proliferating and causing an infection. So that's our main, that's our predominant or our reasons for these infections rather than patient-to-patient spread, which is good. Estates and cleaning compliance for the quarter, for our cleaning compliance for Bowness and Falkirk, we're sitting in the 90s, which is good. Our estates, I think we've probably seen this before, the Falkirk community is a little bit low at 87%. Our Bowness is sitting at 91% for our estates compliance, which the Falkirk one is a little bit, has reduced somewhat, just a little bit from 88% of the previous quarter. Now, there is a new group, the Facilities and Infrastructure Compliance Group, which is now looking at these kind of scores and identifying what remedial work is needed to get these scores up. So work's ongoing with that. Has been a bit patchy about how we've addressed this because of COVID. It's been a lot more tricky, but we've got another meeting next month, so we're hoping, and that is on the agenda, about how we can get these scores up. So I'm hoping then to report in the coming quarters that our numbers will increase. On to incidents and outbreaks. We had one outbreak, and that was of COVID-19, and that was in Bowness, Ward 1. This was when, at the early stages before visits were suspended, and from our investigations, we had one of the visitors who was symptomatic, and that passed on to the first case and then subsequently passed on to another 2 patients. And again, that's the only ones, no outbreaks in Falkirk either. So that's it. And in terms of hospital-acquired infection incident reporting template, so this is any major outbreaks we are mandated to report to the Scottish Government, and we've had no reported cases this month. Just incidentally, looking at the national data, Forth Valley has the lowest reported outbreak levels in the country as well. So I thought I'd just let you know about that. And finally, just to say that with regards to Hei inspections, during the pandemic, the height of the pandemic, we had the Hei inspectorate suspended all their visits, but they resumed them in July. So they are starting to look at predominantly community hospitals as well. So all hospitals have been informed about this. We've had sessions with the senior charge nurses to give them, an understanding about what's expected and so on. Bearing in mind that all our hospitals, including Falkirk, Bowness has yet to be visited, but Falkirk was visited last year. So work is ongoing just to prepare everyone for these inspections. So any questions?
Thank you very much, Jonathan. I'll bring in Margot. I've got a question, but I'll come back to that. But I'll bring in Margot.
More of a statement, and that's a congratulatory one, because I was really excited to hear how prepared Forth Valley was to face the COVID-19 outbreak, and I just would like to, formally thank them for that, and also the sort of leadership which I think Forth Valley is showing among the Scottish boards. And I think the team and the efforts that are made are much to be commended, and the targets, etc. I think there's been a tremendous improvement, not that it was good before, but I think there's a sort of leadership role which our infection rates illustrates. So thank you.
Okay. Oh, thank you. I would like to say I could take the full credit for that, but it's not. I mean, I have looked at this, asked why our rates are so low compared to national, and I think we are very, very lucky to have such a good team amongst us, you know, the nursing staff and all that, you know, because we could, you know, my team could be the best in the country, but if you've got poor nursing staff and nursing care, you're still going to get infections, you know, and we don't. So, you know, this is more to do with the nursing staff at ward level, I think, and they need to have the credit, really, supported by us, of course, and I'll take some of it as well. But it is the nursing side at ward level which are keeping infections down, actually.
I see by Angela's face agreeing 100%.
Yeah, I had written on the chat, Chair, that actually I think just Margot said it and we can't say these kind of things, but I will completely agree with Jonathan that it's a teamwork and the level of compliance around practice in relation to all aspects of infection control, not just PPE, from all of our staff have been immense. And although we're not talking about mental health here today, but within mental health and learning disability at the very early stages, we did have some COVID, and we watched our nursing staff, supported by everyone, as Jonathan said, care for people who are acutely unwell, but that's not something they've done in PPE. And, you know, so what we have seen is staff being tremendous and then paying even more attention to infection control, and the high reliability around their practice is what keeps people safe. And the other side of that was that relatives and others weren't able to come in and visit, and that was really difficult as well. So staff were managing and did most incredible things, particularly around end of life care where people couldn't be with their loved ones. So that balance all of the time where people have handled it beautifully, as well as preventing infections, as Jonathan said. And the infection control team are amazing, by the way, but it is just truly a team effort. And I'm directing infection control in Glasgow, as you know, and we're looking at how everyone else is managing this, and really we have done quite extraordinary, but it's been hard work and focus. I'm sure we've been lucky by the rates of COVID around Forth Valley. I think there's something about how little transmission we had in the community, but notwithstanding that, it's been a great team effort, and just there's been a real feature in today's meeting about teams working together, and this is another one.
Here on that point, definitely. I think the work over the whole pandemic across a number of areas, I think partnership has been absolutely critical to that. I have one question, and it's around the comment you were making about people being potential increases in some infections because of a reluctance to come forward for treatment. And I wondered whether that's something that's still continue, if you've got a sense that that's still continuing. And is there, I know that there's been work nationally on GPs are open, you know, but I know certainly as elected members, we're still getting questions from constituents who think that their GP surgery isn't open. And I just wondered if there was something about that local activity, and I know there's stuff around social media and things like that, and I've definitely seen it, but I just wondered about that kind of bigger picture.
We were discussing this at the antimicrobial management group last week now, because we were looking at the question about, you know, certainly from urinary tract infections, about why we're seeing a little bit more than normal from the community. And we did look, and we've shared the data with our pharmacy colleagues to have a look, seeing whether or not those patients were prescribed an antibiotic that was actually resistant to the organism that was causing an infection. So that data is actually with pharmacy at the moment. So they're gathering the data there, because pharmacy have only got access to the data that's been prescribed in the community. So we're looking at that at the moment, because we want to see, you know, if the patient's been prescribed an antibiotic, a general antibiotic blindly without sending the urine for culture, which might be the case, you know, because of these times at the moment. You know, we want to identify that, and if so, then we can address it. So I'm hoping, you know, once we get the data back from from pharmacy, we should hopefully be able to identify, or either say, yes, that was the reason, or no, it wasn't, and there is another reason. It is purely anecdotal at the moment. I don't know whether or not there'll be some national studies following this COVID outbreak, and I'm sure there will be, to look at the reasons why, you know, because interestingly enough, other infections across the board, like people with appendicitis and things like that, those numbers have actually gone down, but nobody knows why. You know, which is, you'd expect these things to remain constant, but they seem to haven't. You know, so again, we're not sure why. So we're hoping there will be some sort of research going into this and trying to speculate at least why these anomalies are occurring.
That's helpful. Thanks very much. Is there any more questions? Margot.
Just related to that last question that you had, I was just wondering how much evidence there is of people using the pharmacy where access issues are possibly easier than the contact of a GP at the moment. And I know that pharmacies, that's one of the areas that they're sort of giving treatment within. And I just wondered if you have any evidence of their role, and do they do the sampling of urine samples as well?
No, they said, I think the urine sample would have to go through the GP, but I could be wrong there, but I understand. I mean, the pharmacy and the medical staff use what's called the antibiotic formulary. So they're standard antibiotics that you use for particular infections, you know, so I don't think there'll be any discrepancies between that and what would be prescribed compared to a GP. But that's something, you know, I'll speak to pharmacy about when they're gathering this information, whether or not those antibiotics were prescribed by the pharmacist rather than the GP, because I don't know whether or not the pharmacist will have access to previous reports, you know, antibiotic sensitivity results, which would perhaps sway a GP, if they had access to those previous results, whether or not to prescribe a different antibiotic if the general standard antibiotic used was resistant to that organism, or the organism was resistant to that antibiotic rather.
Thanks very much. Is there any further questions? No, thank you very much, Jonathan. I am going to move on to the overview of inspection reports and national publications. Suzanne?
Thank you, Chair. The report provides an overview of local inspection activity for in-house services and a publication of national reports, and that's been since the last meeting to committee. In relation to inspection activity, there have been no reports published since the last update to committee in June. We have, however, at Appendix 1 included updates on inspection reports that have previously been reported, and that was done in response to feedback at the last meeting. Appendix 2 of the report does include a summary of the fortnightly reports that have been recently, in response to COVID, been issued to the Scottish Parliament on care inspection activity, and we've included those reports where they relate to local service providers, so that the committee are aware of those reports. These care inspectorate inspections are assessing the arrangements in place by care services to respond specifically to COVID-19 pandemic. In relation to national publications, there's been one report from the Mental Welfare Commission, and a summary of that's included at Appendix 3. The publication was about a review of psychiatric emergency plans in Scotland, and committee will note from the appendix that we've provided an update in respect to our local response, and that work is ongoing to develop a Forth Valley psychiatric emergency plan. I'm happy to take any questions.
Thanks very much, Suzanne. Does anyone have any questions on the reports? Well, I'll ask a quick one then, because I have a wee note of it. Was a question of, there's quite a few recommendations that have come through from 3 inspections of Wells Dyke, and I mean, it's just a general question. Is there areas of concern or is this an improving picture? I guess that's a general question. I don't know if anyone can feedback on that.
I perhaps can, Chair. So, and we're happy to work with Suzanne to find a way of making sure that you can have update sections. That's what we would normally do, because we do that in other committees. So the colleagues continue to focus on that. There are improvement plans there, and there's certainly been nothing escalated to me to say that we're not on track around there in Belstyke, Fiona. So it may be something that we just want to do so that people can see that the action plans, when they're due, when they're updated, and any further inspections. So, but again, and we can happy to provide Suzanne with anything that's needed in relation to Belstyke.
Thanks, that's very helpful, and I think the how this is laid out is really helpful.
It's an excellent form,
and really gives a clear information on the actions, and I think that is that next step of what the improvement plans and things like that. I think that would be very helpful. Do you have any other questions? Yeah. No. Well, thank you, thank you very much, Suzanne. I think I'm moving back on to you again on the overview of local oversight arrangements.
Thank you again. I'll just keep it brief. The report sets out an overview of local oversight arrangements that are relevant to the Health and Social Care Partnership. And this was just about trying to, that process of starting to map out how things are connecting through and reporting to committee. Updates in the report included are around the Forth Valley Public Protection Chief Officers at section 4. We've included an update on Falkirk Adult Protection Committee, and committee have previously received more detailed reports, so it's a short summary. NHS Forth Valley clinical governance arrangements are set out at section 6, and care home arrangements are set out at section 7, and committees also receive sort of detailed reports around the care home assurance arrangements. Each section provides a short summary of the role of the group and their current areas of work, and colleagues attending the meeting today are probably better placed to provide any more detail around these groups and their action plan. Probably just want to know it's the first time we've sort of pulled together the report in this format, so committee they want to consider the content and the format of the report so that we can develop this further as required. The recommendations at 2.1 to note the content. Happy to take any questions or redirect those to colleagues.
Thank you very much. So, I mean, I certainly found it very helpful to have all those the arrangements all laid out, and also the areas of current work. I certainly found that very helpful. Do you have any questions or comments, or anything anyone would like to add to who's involved in any of these local arrangements? Jen.
Just to add that there's never been a third sector chief officer role in those partnerships yet. I think one of the things we looked at through COVID was how instrumental frontline volunteers, neighbours and things are, and actually bringing forward some of the protection issues and identifying them, and to do that well and feel confident to do that and know how to report them. So maybe not every single meeting, but it might be worth having some of the third sector interface chief officers attend to look at that when it's on the agenda.
I would have a note of that as an action. I think that's a very good point, and I know that you've raised before about the people on the ground are picking up issues and about giving them the right support to be able to know what to do there, but also to be able to feed that into the wider public protection. Sarah, would you like to come in?
Thanks, Chair. Just simply to assure committee that there certainly is third sector representation in terms of the Adult Protection Committee, but I note Jen's point is specifically about the Chief Officer group. So just to clarify that, and certainly would pick this up as an action for consideration by the group.
Thanks very much, Sarah. Jen?
sorry. Yeah, I meant the chief officer group. No, we're absolutely embedded at the adult protection level, but I think in terms of leadership, there is a leadership role there to work with the sector to promote it, to promote that awareness and to help encourage the third sector to to take forward the learning and things that we do through the Adult Protection Committee. And perhaps a Forth Valley-wide aspect to that too, because we do work with lots of these organisations, especially the ones that work with quite vulnerable people across a Forth Valley-wide basis.
That's great, thank you very much. Are there any further comments or questions? Trying to look across my grid. I'm still finding it a little bit difficult. So with that, there's no further questions or comments. So I'd just like to say thank you to everyone and to everyone who's presented papers today. And I hope you all have a lovely day.